Hello, good morning, everyone. We're going to finish up lecture 4 today, and maybe we'll have some time to actually start on number 5 as well. We'll see how it goes. So previously, we were talking about the structure of the lungs, and as you can see here, on the right side of the lungs, there are three lobes, the superior lobe, the middle lobe, and the inferior lobe. And these lobes are separated by these lines called fissures. You don't have to memorize, the names of the fissures. Horizontal, it's like sideways, obviously. Oblique just means it's diagonal, and it separates these the lungs into these different lobes. And there are three lobes in total on the right side. And to kind of make room for the heart on the left side, the left lung only has two lobes, the superior lobe and the inferior lobe, and there will only be one oblique fissure right here. Now, the lungs are pretty light and spongy uh, because they have to be inflatable with air, right? To be able to expand as air comes in. So it's not a rigid structure. There has to be some flexibility associated with it. And as we will see in a moment, there are different factors that would affect the ability for air to flow into the lungs. We also talked about how the lungs are enclosed by a double layer membrane. We actually drew this out last time. You might remember this was the last thing we did. There are two layers of this. There is the pink visceral pleural, which is pleura, excuse me, which is in direct contact with the lung. And then the second layer that is more superficial is the parietal pleura. Okay? And together, they kind of sandwich the pleural fluid in between. So the pleural fluid is important for two reasons. Number one, it allows the two layers to rub past against each other without creating friction. And so as the lung expand and contract, the visceral pleura and the parietal pleura will be rubbing against each other. With the pleural fluid in between, it lubricates these surfaces. Second function is because of the fluid, the two membranes are actually stuck together. They're held together by surface tension. To explain this, I want you to visualize this, okay? If you have a plastic bag, okay, just on its own on the table, and then you have another plastic bag, and then you touch the plastic bag on the table with the one you're holding, and you try to pick it up, not gonna work, right? Yeah. But if you wet it first and then you touch it, now you're able to lift it up. Right? The moisture, the water creates the surface tension that allows things to stick together, basically. Okay, and sticking together in this case allows the movement of one membrane to be attached to the movement of the other membrane. And this is very important when it comes to the ability to breathe in and breathe out. And I'll explain that with a note later on. So this is another picture. If you zoom in onto the lungs, you can see right here, this is the spongy lung tissue. And immediately outside of the lungs, you have the visceral pleura, and then you have the pleural cavity, which is filled with the pleural fluid, and then you have the parietal pleura. Now, the parietal pleura on the side will be attached to your chest cavity. So as your chest moves out and in when you're breathing, it will pull the membrane with it. And at the bottom, and this is where the diaphragm is, the parietal pleura will also be in contact with the diaphragm. So as the diaphragm moves down and up when you're breathing, it will pull the lungs with it as well. Okay, so let me just say that one more time. Visceral pleura is stuck to your lungs. Parietal pleura is either stuck to the inside of your chest cavity or the diaphragm at the bottom. And whenever whenever the chest cavity and the diaphragm moves, it will move the parietal pleura with it. And because of the surface tension created by the fluid, it will pull the visceral pleura with it, and at the same time pulling the lungs with it. Okay, so I'm going to write this out for you. The lung movement is tethered to the movement of the rib cage. Okay, the ribs are here, right? When there are muscles that will pull the ribs out and in to change your chest cavity volume. It's tethered to the movement of the rib cage and the diaphragm. Okay, they are connected. They're tethered. So whenever the rib cage and diaphragm moves, the lungs will move with it. Okay. This is because of the pleura. Okay. Singular is pleura. The plural would be pleurae with an E at the end. Right? Now let's take a look at several factors that would affect the flow of air in our respiratory tract. So number one, we have what's called Boyle's law. Boyle's law. Boyle's law is one of the gas law. I think you might have learned that in your chemistry class last semester. I might be wrong. But Boyle's law is the inverse relationship between pressure and volume when temperature is constant. Okay, so within our body, temperature is pretty constant. It's 37 degrees, as you know. So what Boyle's law says is if you increase the volume of the lungs, that would result in a decrease in the pressure. The opposite is true. If you lower the lung volume, then the pressure in the lungs will increase. So it's an inverse relationship. Inverse essentially means opposite. One goes up, the other goes down. That's Boyle's law. Next, we have pressure gradient. Okay. Gradient, you learn about that in concentration gradient. Things go down their concentration gradient from high concentration to low concentration spontaneously. And that is the same for fluid. Fluids are either gas or liquid. In this case, we're talking about gas. So gas naturally goes from high pressure to low pressure, down its pressure gradient. And the pressure we're interested in when we're talking about breathing would be the atmospheric pressure and the intrapulmonary pressure. So PA is atmospheric pressure. PA, that's the pressure of our atmosphere, of our surrounding. Right? It depends on uh, the how far above the sea level you're at. The atmospheric pressure might differ a little bit, but generally, it would be higher. Well, actually, I shouldn't say that. Okay, but that's the pressure we want to compare with when we are talking about breathing, right? So what other pressure are we comparing with? We are comparing it with the intrapulmonary pressure, right? PI, which is basically, to keep it simple, it is in the lungs. Okay, so this is surrounding. So if atmospheric pressure is greater than, if atmospheric pressure is greater than intrapulmonary pressure, then the air floats which way? Into the lungs or out of the lungs? if the pressure outside it's greater than the pressure inside the lungs, which way is air going to flow? Into the lungs or out of the lungs?
Into the lungs.
What is it? I'm sorry.
Is it into the lungs?
That's right, because it goes from high pressure to low pressure, right? So air flows into the lungs, and this is for inhalation, basically, right? Breathing in. On the other hand, if atmospheric pressure is less than pulmonary pressure, then air flows out of the lungs. Okay, so the first one would be inhale, breathing in. This would be exhale, right? So in order to breathe, your body has to either make the pressure in the lungs to be lower than the outside for breathing in, or it has to make the pressure higher than the outside in order for you to breathe out. And we're going to look at how that's going to happen. Right, so these two things affects the direction of airflow, Boyle's law, and pressure gradient. There are two other factors that we're going to look at. Compliance. Compliance basically describes the ability for the lungs to expand and accommodate the inhaled air. And we can say this is the expandability of the lungs. Sorry, expandability of the lungs. If something has high compliance, like a balloon, high compliance, then it expands easily. Whereas if you think of like a water bottle, it has low compliance. It does not expand easily. So it will be difficult to pump air into something that has low compliance. Okay, you need to force it in with high pressure, right? But if something has high compliance, then it's relatively easy to expand, relatively easy to inflate. Okay? So when it comes to the lung compliance, it is actually related to the amount of surfactant produced. Right? Last class, let me just refresh your memory. We excuse me, we talked about surface tension and surfactant. Surface tension is created by the moist interior of the alveoli, and that actually is reducing the compliance of your lungs, okay, because they're attracting each other, right? It really closes the alveoli, right? And so to counteract the surface tension, to break some of the surface tension, we secrete an oily substance called surfactant. So the more surfactant is created, then the more compliant the lungs are going to be. Okay, so surfactant breaks surface tension, and then it increases compliance. But you do not want to have very, very, very high compliance. Okay, we want the lungs to be a little bit elastic, right? Like the balloon. So when we breathe out, the air is gonna somewhat automatically come out. Right? As we will see later on in today's lesson, uh, long-term smoking, for example, is going to make the lung too compliant, and that makes it difficult for breathing out. Okay, so it's all about having the right balance, right? You don't want to push things towards one extreme versus the other. Finally, we have the resistance to airflow, and this is related to the diameter of the airway. I mean, it's pretty straightforward. If you reduce the diameter, if the airway gets more narrow, let's say you have a stuffy nose or something like that, then you increase the resistance to airflow, and then it's more difficult for airflow. We all had a stuffy nose before, and when it's all stuffed up, it's really the congestion makes it really hard to breathe, right? We might have to breathe through our nose and sorry, breathe through our mouth instead, because everything in the nose is congested. But when it comes to resistance to airflow, it's not just the nasal cavity that can create a congestion. Right? If someone is having an asthma attack, the bronchioles, which does not have the cartilage, they will constrict, and they will also be producing excess mucus. So together, it causes the airway to diameter to be reduced significantly, right? Making it difficult and sometimes impossible to breathe. And again, that's when you have to have the puffers to force the muscles in the airway to relax and to open them up again. So there you go. Four factors that affects airflow. Boyle's law, volume goes up, pressure goes down, vice versa. Number two, high pressure to low pressure. Number three, compliance. Number four, resistance to airflow. So we're going to draw some diagram right now to talk about what are we going to talk about? We talk about mechanism of breathing. Okay, mechanism of breathing. I should start a new note. It's already February. Can you believe it? February 3rd. And we're week five. Yeah. So almost halfway through the course. All right, let's write this down. Mechanism of breathing. So here is a thing people uh gets confused about. Give me 1 second, sorry. Having a little bit of congestion myself this morning. Um, oh, there's a question, by the way. Do we need to watch class recordings to do labs, or lab videos is enough? Yeah, I think lab video is enough. Actually, I the lab videos are I updated the PowerPoint files. I don't know if you guys know. Uh, the link to the videos is inside the PowerPoint now. So, you can just click on them and watch it. Basically, it gives you a better understanding of the models, right? So, yeah. The lab, by the way, is due on Wednesday. Okay, so make sure you take the time to do that. Wednesday is the lab 2.5%. We also have class on Wednesday, and then the test will be on Friday, right? Friday, this Friday. Okay, so breathing. Let's do this. Okay, let's breathe. Okay, take a deep breath in, and then you feel your chest moving out, right? Right? So here's the question: which happens first? Did the air go in and then your chest moves up, or did your chest move up first and then the air goes in? Yeah, you don't have to answer me. You can just think about it. Just think about it, right? Right, take a deep breath, and then you feel the chest moving. Right? Which happens first, right? So that's an interesting thing that people sometimes got it wrong. So let me explain to you here, and hopefully you will see whether you're right or not. So let's talk about inhalation. Inhalation. Inhalation is breathing in, right? Okay, bringing air into the body. So I'm gonna draw some pictures here. It's an exaggeration, okay? To help you understand. This is the head, and this person is trying to breathe in. So to breathe in, again, this is an exaggeration, all right, to just help you understand what's going on. Right? So to breathe in, two things needs to happen simultaneously. Okay, number one, the rib cage. The rib cage moves upward and outward. Okay? Out and up. Think of a bucket and then the handle. Okay. When you lift the handle, it goes out and up, right? So that's what I'm trying to tell you here. The rib cage has muscles that would pull it out and up. If you enjoy eating barbecue ribs or something like that, the meats you're eating are basically the meats that helps the cow or pig breathe. And we have those muscles as well. Pulls the rib cage out and up. And at the same time, down here, we have the diaphragm. Okay, the diaphragm would contract. I see guys write down the diaphragm contracts, flattens, and moves down. Okay, so your diaphragm, if you take a look at my camera here for a second, diaphragm is normally dome shaped like this. Oh, sorry, I think my background is blurred because I was in another meeting. There, okay, so this is dome shape, that's normal shape. When you want to breathe in, it flattens, okay, and then breathe out. Breathe in, breathe out. Okay, so if you want to inhale, it has a contract, flattens, and move down. That's what it needs to do. Now, because of the membrane around the lungs, the pleurae, whenever the rib cage moves and the diaphragm moves, it will pull the lungs with it. So when these two things are happening, your lungs will follow it. Your lungs will follow it. Okay, so this is number one and number one, they happen at the same time. And then event number two is that the lung moves with the rib cage and diaphragm. Okay, lung volume increases, and that causes lung pressure to decrease. This is Boyle's law. When the lung pressure is less than, we call it PI, right? Intrapulmonary pressure. As the pressure drops and it goes below the atmospheric pressure, then air enters the lung. Right? So air is going to come in like this. Right? So you see, in order for you to breathe in, right, you actually have to move your chest and your diaphragm first. The movement of the rib cage and the diaphragm creates the necessary condition for air to come in. Right? But it doesn't feel that way, right? It feels like the other way around. It feels like see, I breathe in and I see my chest going up. But again, it's the other way around. If your chest cannot move, if something is like compressing on you, okay, like if something heavy is resting on your chest, like someone trapped in like a collapsed building or something, then it's very difficult to breathe in, right? Because now you cannot expand your lungs, right? You cannot expand your rib cage. Okay. Any question about inhalation? Oh, all right. I think that's pretty clear. Hope that's pretty clear. Let's do exhalation. Okay. Exhalation is, of course, the other way around. Okay. So again, this is an exaggerated drawing. Okay. It's not that extreme of a change when it comes to the movement of the chest cavity and the diaphragm. So in this case, the rib cage, okay, rib cage moves downward and inward. There are actually a separate set of muscle that will pull the rib cage down and back in. And then the diaphragm, which is down here, diaphragm relaxes, moves up, and resumes dome shape. So collectively, these action, okay, uh, I'm not going to rewrite the whole thing, but basically these things will cause the lung volume to decrease and lung pressure to increase. And when PI is greater than PA, then air leaves lungs. Okay. Not sure why I wrote this in red. Let's just change it back. Oh, never mind. Doesn't matter. Okay. It's not like anything special or something, okay? Um, just same as before, but opposite. So that's breathing in and breathing out. Any questions? Okay, no questions. Very good. This is what it looks like. You can see on the left, we have exhalation with the diaphragm moving up, the ribcage coming in, and then for inhalation is the other way around. It's basically what we drew here. Right? I forgot to put the air arrow there. It's breathing out. Okay, let's see if you learn anything. Go ahead. All right. So which of the following is anatomically correct? The visceral pleura is superficial to the parietal pleura. That's not true. Visceral is touching the lungs. So it's not superficial, it's deeper. The trachea is posterior to the esophagus. That is not true. The trachea is in front of the esophagus. So that would be anterior, right, with a C-shaped ring around it. The diaphragm is superior to the lungs. Nope. The diaphragm is actually below the lungs, so that would be inferior. So the correct one is D. The lungs are lateral to the sides of the heart. Let's do one more. This is about breathing and airflow. Okay, not too many answers coming in, but that's okay. I think I'm just gonna leave it at that. So we're looking for the true statement. Number one, increasing volume will increase pressure as well if temperature is constant. That is not true. It's the other way around. Increasing volume will decrease the pressure, right? Because of Boyle's law. Boyle's law. Um, okay, there's a question about pressure gradient. Sure. So, pressure gradient. Okay, so first of all, what's a gradient? A gradient basically is just a fancy word for difference. Okay, so you can have concentration gradient between 2 points. That means one point has higher concentration than the other point. If we're talking about a pressure gradient between 2 points, it means one point has higher pressure than the other point. For example, if you blow up a balloon, if you you know inflate a balloon and you hold the neck, then the pressure here is high compared to the pressure in the surrounding, which is low. So as soon as you open up the neck, then the air will come out from the balloon by itself because air will always flow from high pressure to low pressure down its down its pressure gradient. Does that answer your question, or you want me to give you another example? Yeah, okay, yeah. Same as those spray can, right? Okay, Febreze or whatever you spray. The inside the canister, the pressure is higher than the outside. So as soon as you depress the valve, they automatically come out, go from high pressure to low pressure. Okay, so back to this thing. Increasing lung compliance will make it easier to inhale. Compliance is the ability for the lungs to expand and to receive the incoming air. So more compliant means easier to expand, easier to inhale. That is correct. C, reducing the airway diameter will lower the resistance. No, this will increase resistance because if you reduce the airway, it's more narrow, right? If it's more narrow, it's more difficult for air to pass through. Right? Resistance is like pushing back, right? Preventing the air from going through, right? So this is false. Air will naturally flow from low pressure to high pressure. No, it's the other way around, right? As I just explained with the balloon thing here. All right, so the correct answer is B, compliance. It's going to make it easier to inhale. All right, let me explain a few other situation with you. Next one is breathing at high altitude. Okay, breathing at high altitude. So let's say this is the mountain top, and then this is like, you know, close to sea level. Okay, so let's say you're here. So you're here, and then you're gonna go up to a high mountain. Okay. So where would you experience more atmospheric pressure? At sea level, closer to sea level, or higher up in the mountain? Which one will you experience more pressure? Closer to sea level, right? That's right. Because you have more air above you, right? So this is going to have higher atmospheric pressure, higher PA. And then this is going to be lower PA. The air is thinner, as they say. So I'm totally making up these numbers to help you understand. Okay, these are not real numbers. I'm just saying, let's say it is 100 atmospheric pressure here. So in order for you to inhale, in order for you to breathe in, what must your lung pressure be? Is it going to be higher than 100 or less than 100 if you want to breathe in? Mhm. So based on what I explained earlier, your lung has to have lower pressure than the outside for air to rush in, right? Because of the pressure gradient that we discussed. So, let's say your lung pressure can decrease to 60. Again, these are not real numbers. I'm just keeping it simple to help you understand. So you are able to create a difference of pressure. Triangle means difference. A difference of 40 units of pressure. Okay? So you're gonna hike up the mountain all the way to here. Now the atmospheric pressure is lower. Okay, depending on how high you go, it could be substantially lower, right? Or, it's like a little bit lower. So let's say you hike really high up, okay? Then up here, it's like only 70 units. So what's going to happen with your breathing? Well, if you're only able to make the lungs go down to 60, then now you only create a pressure difference of 10. So not as much air can go into your body, right? And on top of that, about 21% of the air that we breathe is oxygen. So not only are you breathing less air into the body, you're also getting less oxygen because the air is thinner, right? At higher te atmosphere. So these things combined can make it difficult, if not impossible, to breathe at high altitude. Okay. Now you might think, hey, why don't we just drop the pressure further? Why don't we just drop it down to, 40, right? Then we can still have adequate pressure difference to move more air in. Don't forget, when you need to drop the pressure of your lungs, your chest has to move out and up, and your diaphragm has to move down. But there is a limitation for how far you can move the chest out. Right? You cannot move your chest out indefinitely, right? Similarly, for your diaphragm, you cannot push it down indefinitely, right? There are physical constraints as to how far you can push these limits. So once your chest is as far out as you can move it, and the diaphragm is as low as you can push it, then you literally cannot expand your lungs anymore, and you cannot drop the pressure any further, right? So there's only so much air you can breathe in. So people who hike up like Mount Everest, for example, that's why you see them carrying oxygen masks because beyond a certain point, they call it the death zone, right? That's because the air is like too thin. You can't breathe it in, and even if you can get it in, there's not enough oxygen, and you have to wear the oxygen mask. Okay. And that's why if people get stranded up there, like you can't even fly a helicopter to rescue them or something, right? Beyond certain point. Because if the air is too thin, then helicopter can't fly, right? It's a little bit of physics. Helicopter flies by pushing air down, and then the air lifts it, right? It's Newton's third law. If there's not enough air to push it down, then there's not enough lift to fly the helicopter, right? So like you can't rescue those people. The only way to rescue them is to send more people up, right? There are so many documentaries on these things on YouTube, Netflix. You guys can check it out if you're interested. Regarding the climbing and the oxygen, that's what I'm talking about. Okay, so another thing is if this is the case, then airplanes are flying like much higher, right, than the mountaintop. Then how come people can breathe in an airplane? Well, the answer, I'm sure you already know, it's quite simple because the cabinet of the airplane is pressurized. Okay. And so you're still going to be able to move, to breathe, right? There are a lot of things that movies get wrong, but one of the things they did get right is, whenever they have a airplane scene and, someone fire a gun or something, or if there is something breaks off, you see things being sucked out and being pulled out of the airplane. That is actually true because the cabinet, as I said, is high pressure. And then if there is any kind of opening or leak in the plane, then things will get pulled out to the low pressure outside, right? And that is just part of the pressure gradient. So if the cabinet does lose pressure, those masks, right, will ensure you can continue to breathe normally because it's applying positive pressure to your system. Okay? I also want to mention two other things that might be interesting for you guys if you're working in healthcare. There are two kinds of rooms that might be reserved for certain kind of patients, and there are negative, negative pressure room, and then there are positive Positive pressure room. Okay, so I want you to think about what that means. Okay, so this is the room. Okay, room. Okay, this is the patient. Okay, on the bed, doesn't matter. Okay, so this is a negative pressure room, which means the pressure of the room and the pressure outside. Okay, the pressure of the room is less than the pressure outside. Okay, so what does this mean? Well, it means whenever the nurse or someone comes and open the door, which way is the air going to move? Into the room or out of the room? Okay, this is negative pressure room. The room is going to be lower pressure than the outside. So whenever you open the door, which way will air go?
In.
That's right. Air is going to go in, right? So in what situation would you put someone in a room like this? As opposed to the other way around. Let me draw it out first. As opposed to same situation, same room. Not very good with the drawing this morning. Okay, but this time the pressure of the room is greater than the pressure outside. So if you open the door this time, it's gonna blow out instead. Okay, so who do you keep in which room? Okay, I already get some answer coming in, and it's correct. Anybody want to share? Okay, let's say this one first. Who should you keep in there? Oops. No, not much idea. That's all right. So for here, you want to put someone who has some kind of infectious disease that can be spread through air. Okay? Because if they cough all over the place like that, okay, there's all the germs here, and you open the door, you don't want these germs to come out and infect other people. So it's negative pressure. You open the room, air goes in, and it's like just push all these germs and keep them in the room, right? Okay, so this is to protect others from whatever infectious disease the person has. Okay, so it could be like some kind of pneumonia or something like that. Okay. And over here is the other way around. This is to protect this person. This person has some kind of immune vulnerability. Okay, so this person is vulnerable to spell it wrong. Vulnerable to some kind of infection, right? So like there might be germs outside, and we don't want it to go in because this person has a compromised immune system. Right? So you open the door, and then the air will basically keep blowing out of the room. It keeps dangerous stuff out of the patient's um, room, and these people would be kept in isolation. Does that make sense? I hope so. All right. Why do we not receive enough oxygen in low pressure environment? Still because, yeah, so there's two problems, right? Number one, you are not getting enough air into the body. When I say air, I don't mean oxygen, right? Air as in like all the gases in the air, right? Okay. So over here, uh, again, this is not accurate math, but I'm just saying, okay? Let's say you're able to get 40 units of air into your body and 20, let's keep it at 20% for easier calculation. 20% of it is oxygen. So what's 20% of 40? Okay, 20% of 40 is 8, right? Okay, 8 unit of oxygen into your system. Over here, you are getting less air into the body, And so you're only getting like 10 units of air into the body. And again, up there is still around 20%. And what's 20% of 10? Well, 20% of 10 is 2, right? So you're getting less air and you're getting less oxygen, right? So it's like double whammy, right? As they say, it's two negative things that's contributing to um, the person not being able to receive enough oxygen in a low pressure environment. Does that answer your question? That's a good question. Okay, what are we doing next? Okay, we're talking about breathing next. Uh, the urge to breathe, actually. So to hold your breath for some time, eventually you will have no choice but to start breathing again. Yeah. You can manually override the breathing mechanism, right, for up to a point, beyond which your breathing center is gonna not allow you to voluntarily hold the breath anymore, and then you will start breathing again. So the breathing center, the respiratory center, is located in part of your brainstem. We'll learn about the brain next unit. The brainstem is really big. It has the midbrain, the pons, and then at the lowest portion of the brainstem is something called the medulla oblongata. Medulla oblongata. It contains the respiratory center. Now, this respiratory center is sensitive primarily to the levels of carbon dioxide as well as hydrogen ion. Okay, a lot of people has this misconception. They think it is oxygen that's controlling how fast you breathe, but it's actually how much carbon dioxide you have in your blood that causes you to change your breathing pattern. The more carbon dioxide you have in the blood, the greater the urge you have to breathe. So basically, when you're holding your breath, your carbon dioxide level keeps on going up and up and up and up because you're not breathing them out, right? And then when it reaches a particular threshold level, it will trigger the respiratory center in the medulla oblongata, and then you will have no choice but to breathe. Same thing with hydrogen ions. So a little bit of chemistry here. Uh, if the carbon dioxide start building up in your blood, they will combine with water. Can someone tell me what the product is for carbon dioxide plus water? Did you guys learn this in your chem class? Anybody at all? No? You haven't done this or you don't know the answer? There's a there's a difference. All right, that's fine. So carbon dioxide plus water is gonna give you H2CO3, which is carbonic acid, okay? It's the same stuff that you will find in soft drinks. And then what's gonna happen is the carbonic acid will actually break down into H plus and bicarbonate, HCO3 negative, right? So when you have a lot of H plus in your system, it is actually an indication that you have too much carbon dioxide building up in the blood. And that is an alarming trigger for your respiratory center to make you breathe, to force you to breathe, basically. Okay. So the center, the respiratory center, is not directly affected by low oxygen levels. Okay. It is only going to detect carbon dioxide and H plus. Anyways, if you get lost in everything I said, if I ask you what gas is primarily responsible for driving the urge to breathe, please say carbon dioxide. Now, there are other sensor in the body. They are called carotid bodies. You might or might not remember you have a carotid artery that goes up to your brain. Uh, Within those arteries, as well as the aorta, you have these carotid bodies. So the carotid bodies are there to detect oxygen levels, And they will, like, for some reason, if the high level of carbon dioxide and H plus is not sufficient to force a person to breathe, then the carotid body will be kind of like a backup system. Okay, it's like, hey, we're really running out of oxygen here. You really got to start breathing, otherwise, we're gonna pass out. And then it's going to basically send signal to the respiratory center and force a person to breathe. Right? So there is a story that goes like this, right? Like there are some kids who are really, really stubborn, and they I don't know where they would learn this, but they're like, if you don't give me what I want, I'm gonna hold my breath until I die, right? And the traditional wisdom is you can let them do it, because it's not possible, right? To hold your breath and die that way, right? You hold your breath, eventually your brainstem will override the voluntary breath holding mechanism, and then you will start breathing again. They might pass out, which could be a scary experience, but once they pass out, they will lose the voluntary control of holding their breath, and they will start breathing. Now, speaking of which, let's talk about holding your breath. How long do you think you guys can hold your breath for? Anybody, is really good at that? And even if you're not really good at it, like, roughly, how long do you think you can hold your breath? 4 minutes? Are you for real? Wow, that's really long. Like you swimmer or something? 3 seconds? Oh, come on, you can do better than 3 seconds. Yeah. So we have two extremes here. We're really good at holding the breath, and then the other, it's like being overly modest. Uh, yeah, I would say most people can hold their breath for anywhere between 30 seconds to 1 minute. Okay, that would be a reasonable, really? 10 seconds? Okay, yeah, maybe. Okay. But anyway, here's something you can try, okay? Um, if you want to. Before all right, so actually let me do this graph for you first. This is carbon dioxide level in blood, okay? And this is time. So when you're breathing, right? In and out, right? So when you breathe out, you're actually breathing out carbon dioxide. And if you hold your breath after you breathe in, right? Then your carbon dioxide level is like down here because you just breathed out not too long ago, right? So it's not going to be zero, but it's not going to be high. And when you hold your breath, the carbon dioxide level in your blood will slowly build up over time. Build, 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 build. And then when you get to a particular threshold, then the respiratory center in your brainstem will force you to breathe. Right? So you can't hold it anymore. And then take a deep breath, and then you breathe out all that carbon dioxide. Right? So that's basically what's happening. Right? This is for regular breathing and holding your breath. Now, what you can try is this. Okay, you can inhale and exhale deeply, and then like that, and then you do it 10 times. Okay, right? And on your 10th breath, okay, once you breathe in, then you hold it and then you time yourself. You can almost double your regular breath holding time, okay? And no prior training is required. If you do that for 10 breaths and then you hold your breath, you can almost double your breath holding time. And the reason is this: when you are deep breathing like that, you are actually getting rid of more carbon dioxide than you normally would. And so when you hold your breath at the end, your starting carbon dioxide level is lower than what it would have been normally. So it takes a longer time to build up to that threshold before you have to exhale. Does that make sense? And so this is after hyperventilation. You are able to decrease the starting carbon dioxide level, and then it takes longer to build up before your body gives in. So it's like tricking your body, right? You're not actually getting extra oxygen. You're just trying to force your brain to not breathe. Do you guys know those deep divers? Yeah, sorry, not deep divers, deep free divers. Free divers. They don't have any diving equipment, and then they just go. They just go very, very deep. and they could go for a very long time. Not scuba divers. They don't have a tank. These are free divers. Okay, free divers. They have nothing. Okay, they just go dive down, and there is a like a competition apparently. So they start on the surface, and then there's a rope, and then the person has to go down as deep as they could, and along the way there are like little tags that they could grab, and the person who can grab the deepest one and then come back up and would like try to break each other's record, right? Yeah. No, it's not just movie, it's for real. Yeah, so there yeah, some fishermen actually do that. In Japan is very common, I think, like in before, right? And I'm sure, there are some places still practice this. But this is an actual thing. And there was a documentary I saw on Netflix. I'll post a link if you guys are interested. About this person trying to push her limit and break the record. And basically, what happens is she goes down, and then once you go down, there's nothing else you can do. Even if you run out of air midway, nobody can help you. Because people who are like wearing the scuba diver tanks, the pressure in the tank is atmospheric pressure, right? And when you're all the way down there, your lungs is like shriveled up to very, very small, almost like the size of your fist, right? And so even if you give them those scuba diver oxygen, it will just literally cause their lungs to explode because the pressure is so high, right? So there's nothing they could do about it if you pass out underwater, and that's what happens to some of these people. They actually die trying to break the world record as to how far they can free dive, right? And anyways, it was just a very profound documentary that I saw that caused me to, you know, just like, wow, people can do this, right? Go so deep with no help, and yet basically putting their lives at risk every time they do it. Anyway, I'll show you the trailer on the after class or something like that if you're interested. Um, all right, so that is the urge to breathe. What else do we have to do? Let's see. Oh, yes, there we have to do this thing. Let's draw another note here. Do, do, do. All right, so I want you to draw a graph like this. Okay, half a page. Right. This would be volume of air. Okay. Doesn't We're not going to put the unit. We're not actually going to use numbers. Volume of air, and then this is just like time over time. So as you are sitting there, you're breathing in, you're breathing out. Normally, we all have to breathe. So the volume of your lungs is going to increase, decrease like that. It has been going on for the past hour as you're sitting there listening to me. So this predictable change in lung volume that goes up and down. It's about 500 milliliters typically. And that is what we call the tidal volume. Tidal volume, just up and down, up and down. Okay. Now, at the end of your regular inhalation, if you continue to breathe in all the way until you cannot breathe in anymore, then you would be sucking in additional air. You'd be sucking in additional air, and it's going to go up to some maximum level. Okay? Then you cannot go any further because your chest cannot expand further out. Your diaphragm is all the way as flat as it could. You can't expand the lungs anymore. And that's the maximum lung volume. Okay? So that extra bit of air that you just inhale is called the inspir inspiratory inspiratory reserved volume. Okay, IRV. Uh, do I have the definitions on the PowerPoints? Nope. But it's basically what I said, right? I guess I can write it out for you. Is the extra volume of air you can inhale beyond normal inhalation. Okay. Imagine doing the dive, right? You're gonna have to take in as much air as possible. So that extra bit that you take in, inspiratory, reserve volume. All right. As you breathe it back out like that. And then you can resume your normal breathing. Okay. Tidal volume, like the water coming in and out at the beach, right? Tidal. And then the opposite can be true, right? You can breathe out as much as you can. So all the way until you cannot breathe out anymore. And don't go all the way to zero. You're just gonna go down, right, before coming back up. So this here, this extra bit of air that you breathe out is called expiratory. Expiratory reserve volume. I have the definition in the study guide for you to match up, so you can work on that if you want later. Okay, so this is expiratory. I think it's spelled that expiratory. Expiratory. There's no S. Expiratory reserved volume. This one has an S though. Okay. Extra volume of air you can exhale beyond normal exhalation. Okay? I'm not going to write it. I think it's pretty self-explanatory. It's the opposite of that, right? So even if you breathe out as much as air as you can, your lung volume is still not going to be zero. It's still not going to be zero. What you have left in your lung is called the residual volume, or RV. Residual volume does not get exhaled. Okay? It's actually called the dead air in the lungs. They don't come out. They're just like sitting there at the bottom of the lungs, so to speak. They never come out, and it's just sitting there. It does not participate in gas exchange because it's very high in carbon dioxide, does not participate in gas exchange. It's useless anyways, because too much carbon dioxide, not much oxygen. It's about 1 liter of residual volume in the lungs. Okay, total lung volume is about 6 liters, depending on the size of the person, right? So roughly, this makes up 16% of your lung volume. Okay, it's just sitting there at the bottom, not really doing anything. So how do you get the residual volume out? You don't, like I said, right? Normally. The only time the residual volume might come out is if you pop your lungs. And so if there's some kind of puncture wound, right? Or like a stab wound, right? Then the lung would deflate. And even so, after the lung deflate, uh, and some of the residual volume comes out, there will still be some air, some volume left in the lungs. And this would be called minimal volume. And this is after lungs collapse. Okay? It's part of the residual volume. Okay? So even if you pop your lungs, not all of the residual volume will come out. Most will. And then you are left with a collapsed lung. Any questions about these volumes before I tell you more? No? All right. So what we can do is we can add up these things. We can take the lowest volume and then I add up the tidal volume and the inspiratory reserve volume, and we get our vital capacity, which is IRV plus tidal volume plus ERV. This represents the maximum volume of air that can be voluntarily moved into or out of the lungs. Okay. So you can actually find out about your vital capacity. You can just inhale as much as you can, all the way until you cannot inhale anymore, and then you breathe out into a balloon until you cannot breathe out anymore. Then, however big the balloon is, that's your vital capacity. Okay. So people can be hooked up to a machine. Basically, they pinch the nose and then they breathe through a tube, and then the tube will be hooked up to this machine that monitors the change in the volume. And it's called spirometry, and the changes in these volumes gives the physician or sometimes the physiotherapist an idea of how fit the person's lungs are. Right? This would be important information for not just for people who may be ill, right, but for athletes who are training as well. Right? They want to have these kind of information, right? So that is that. Right? It's like this. There's the tube, and then it goes into the machine. All right. Let's see if you know this one. It's pretty straightforward. It's basically what I told you. Go ahead. Okay, get my usual few responses here. The amount of air that would could be voluntarily expelled at the end of each respiratory cycle, that would be the expiratory reserve volume. Okay, expiratory reserve volume. It's how much you can breathe out, right? Voluntarily expel. Expel means like getting rid of, right? That would be expiratory reserve volume. Hey, how about some math question here? Maybe we'll just do it together. The vital capacity is 6,000 milliliters. Tidal volume is 500. ERV is 1,000. Total lung capacity is 7,000. What is the IRV? So I wrote it down for you. The vital capacity is IRV plus TV, tidal volume, plus ERV. Let's take a look at the graph again. Vital capacity from the top all the way to the bottom. I told you you can breathe in as much as you can and then breathe out all the way into a balloon. Then you will see your vital capacity. And then we're trying to find the IRV. So vital capacity is 6,000. IRV is X plus tidal volume 500, ERV 1,000. So that's 6,000 equals to X plus 1,500. To solve for X, you subtract 1500 from both sides, then you get 4500. So the answer is A. Okay. The total lung capacity is extra information. It's not needed. Okay, why don't we take a break and then we'll resume in a bit. Uh, Here, I post a link to the documentary trailer that I was talking about. You can watch it during the break if you want. We will come back at 9. Let's do 9:48, okay? 9:48. See you guys in a bit. Okay, welcome back. Before we continue with the lessons, I just want to show you where things are. This is, of course, our course home page, and we have lab number 1 here. And in case you missed it for some reason, you are supposed to complete the PowerPoint slides on your own. You do not need to submit this. And I've added the video link in the PowerPoints for you to watch an explanation of the model that should help you answer some of the questions. I mean, some of this are pretty self-explanatory. Like you probably know this is the aorta, but then, when it comes to, these things over here, you might, not have a harder time telling what it is. So, just watch the video just in case. There is some external link that you can click on. This one is quite fun. The blood typing game, it helps you understand blood transfusion a little bit more. So anyways, you will go through all these things on your own. I think it's good to print it out or, at least have it on your computer and type out the answer so that you have it with you. The lab quiz will be, it's already available to you. It's going to be due on Wednesday, midnight, 40 minutes. And this one, the lab quiz is 2.5%, and it contains all of lecture 1, 2, 3, and 4. Okay, 1, 2, 3, and 4. The test, which is happening this Friday, as you can see here, covers topics from lecture 2 to 4 only. So no cardiovascular system. There is a review file you can do. This is the answer key. And if you need to hear me explain the answers to you, you can watch the review video. Okay. It's an old one, so some of the things um, like at the beginning, I was showing people where to find things. So that was like another platform. Just skip all those parts. Okay, just skip directly to the review portion. And then that's the test. The test is not available to you yet because, like I said, it's gonna be on Friday. It's gonna be available from 6 a.m. all the way to basically 11:59. Time limit is 75 minutes. There will be 34 multiple choice questions and 8 multi-select questions. Okay, that's that. 2 to 4 only. Does anybody have any question? The test is 20%, by the way. Okay. Unlike last time, I did the setting wrong last time. So this time you won't be able to see your grade immediately. You will have to wait until everybody has finished their test. Probably the next day. Any questions? Okay, the test is a little bit harder than the quiz, right? Quiz was well done, right? Class average was really high, but this time is a little bit more challenging. You do have more multi-select questions, so please study and prepare accordingly. Yeah, I know it's a lot of work, but we are getting you ready for the for your next program. So hang in there. Okay, we're just gonna wrap up the lecture with a bit of information about smoking and other conditions. So for smoking, Tobacco is the only legal consumer product that kills half of its regular users. I mean, that is a really strong statement, right? Think about this. If I say there is a 50% chance that the vacuum is going to kill you if you use it, then no one's gonna vacuum their house, right? Because that's a pretty high chance of dying. You have a 50% chance of dying from using it. And yet, that's what's happening with the smoking. Okay, cigarette either directly or indirectly kills them um, half of the time. Globally, cigarette smoking kills 4 million people each year. This is a little bit old figure. It might be a little bit lower now in some parts of the world because of efforts to try to curtail the number of new smokers. But in developing countries, it is as high as 70% of the death is related to smoking in one way or the other. Non-smokers are also affected because they are exposed to secondhand smoke. Secondhand smoke is as bad as smoking directly. And if you can smell, if you can smell it, then you are inhaling secondhand smoke, basically. Okay. That is why Ontario banned smoking in indoors, right? I think more than 10 years ago now. And also you're not allowed to smoke in a vehicle with minors in it, okay? Because of secondhand smoke effects. So this is prevalence of tobacco use in males, and you can see in developed countries it's more prevalent than other parts of the world, and similar patterns can be observed in females. Okay, you can just look at the heat map yourself later on and study a little bit if you're interested in the statistics. But typically, male smokes more than females in developing countries. And then the trend is it's a little bit different in developed countries. For example, like if you look at America, right? Like there's quite a bit of female smokers as well. Okay, let's take a look at the effects of smoking on the respiratory system. I was gonna take a note with you, but I think it's okay if I just show you the pictures and talk about it. So that will save some time so we can move on to other stuff. So, right off the bat, you can see the lungs of a smoker is not too pretty compared to the normal lungs of a non-smoker. You can see there is a lot of buildup of these chemicals from the smoke on the outside as well as the inside of the lungs. And all these chemicals that are exposed, that the lung tissues are exposed to, many times they are irritants that would cause agitation of the respiratory system. There are also carcinogens that can cause cancers, as well as mutagens that could cause mutations. Okay, so carcinogens, they cause cancer. Mutagens, they cause mutations. Mutations don't always result in cancers, but they certainly will increase the risk substantially. Okay. The cigarette smoke also cause the cilia in the airway to become paralyzed. Okay, and if the person smoked for a long time, then the cilia will actually be destroyed and they won't come back anymore. So in the normal bronchi, you can see nice cilia here. And again, the cilia helps remove trapped particles, and it's part of your physical barriers, right? To prevents infection and that kind of stuff. So if the cilia are damaged and you are left with patches of these exposed surface, then it increases the risk of respiratory infection. Okay. And also asthma, because now the airway is more sensitive and pollutants and allergens are not being removed effectively, and that could increase the risk of getting asthma. And also, a person might develop what's called smoker's cough, which is basically a person, trying to remove trapped particles in their airway that normally would be swept up by the cilia, but now there's no way to come up, so you have to forcefully cough them up and spit it out in most cases. So that's another effect. Now, a little side story here. Um, does anybody know what asbestos are? Like where do we see them? What do we use them for? Anybody know? Have you heard of asbestos before? Okay, so asbestos is used as a fire retardant. It slows the spread of fire in buildings in case there is one. And a lot of old buildings use asbestos. Okay, that's what they look like. But what happens is they found out eventually that asbestos is a very potent carcinogen that cause a very specific type of lung cancer called mesothelioma. Okay, mesothelioma. This is the lung with the least mesothelioma, and it's very potent, meaning you don't need to be exposed to a lot of it to have this form of cancer. People who used to go into the mines are exposed to asbestos, so it's not surprising that they get the mesothelioma, but their family members can also get mesothelioma just by being exposed to tiny residues that are left on the clothing of these men. Sorry, someone asked me to explain what asbestos are. They are mostly used in older buildings um, for fire retardant. Okay, it slows the spread of fire, okay, if there is one that breaks out. Yeah, so we don't use asbestos anymore, I don't think, in buildings, because now we understand it's a dangerous substance, right? And that's why when they like tear down old buildings or if they do major renovation in old buildings, they have to call in specialists to seal off the area and make sure when they take things apart, the asbestos that might come out is not gonna go everywhere, right? It's going to be contained, right? Because it's once again going to cause lung cancers for people who are exposed to it and inhaled it, even in quite small amount. So how is this related to smoking? All right. So there used to be this brand. I don't know if they still have this brand. I don't smoke, so I don't know. Was this brand called Kent, and they have these tobaccos that they sell. And at the time when smoking first became a thing, people didn't know about the negative impacts, right? It was like, it's kind of like chewing gum, right? It's just a thing people do, right? It's like maybe for leisure and then for uh, I don't know, for its relaxing properties, maybe. Okay. But later on, the scientific communities and the medical community start to point out, okay, smoking is actually not good for you. It causes all these lung problems and potentially can give you cancer. And so this particular company was trying to kind of salvage the bad image that was imposed on tobacco. I mean, people are still doing it, right? To basically boost tobacco sales, right? It's a lot of money, right? Even though they have all those warnings on it. Uh, but anyway, so they were trying to salvage the image of smoking. So you can see they hire, people who look sophisticated and they're smoking. But the thing is, they're saying that our brand of cigarettes has a micro filter, right? So more scientists and educators smoke this brand because it has these special filters, right? And it's supposed to filter out all the bad stuff, all the harmful stuff, and you can just still enjoy your smoke without having to worry about the negative impact, right? So people, bought into the idea, and I think sales went well for them. But guess what? The irony was, the microfilter actually part of the ingredient was asbestos. Okay. So sure, people are maybe they're not getting as much of the toxin being inhaled, but they're gonna definitely be at a much higher risk of getting the mesothelioma. Okay, so scary stuff. Of course, nowadays, the cigarettes package they have all those scary pictures on it, with the rotten teeth and then the cancer and the tumors. And I think most recently, last year, the Liberal government they passed a legislation where each individual cigarette has a label on it now, right? It's like this is poison or something, right? I don't know. I honestly don't know how effective that is. Like, I mean, it's people who are smoking will not be bothered by that extra label, right? It's like when I buy junk food, I know it's bad for me. I know I shouldn't be eating that bag of chips, right? Like if you put a label and it tells me that this is gonna increase your heart risk of heart attack, I'm not sure if that's going to stop me from buying the bag of chips, right? I imagine it's the same thing for people who smoke. Anyways, I think there needs to be tougher regulations to regulate to reduce the number of people who are smoking. I think in Ireland, I'm not 100% sure if it's Ireland, but it's one there is a one country where they are increasing the minimum age required to buy cigarettes by 1 year every year. Okay. So for example, like right now, it's like 18 years. You have to be at least 18 years of age to buy cigarettes. Okay. Starting next year, the cutoff will be 19 years. Starting next year, the cutoff will be 20 years. So basically, they are pumping up the threshold, and eventually you won't be able to buy cigarettes until you're like, I don't know, 60 years old or something, right? So in that way, they are kind of weaning out the population of smokers because they can't buy it legally. They can't buy it, right? So over time, the population will hopefully have no more smokers, right? So that's I think is an effective way. But like I said, money talks, right? And tobacco generates a lot of revenue, for the government, to be frank. And so it takes a lot of political power to legislate that kind of new rules and new laws. And I'm not sure if as a country we are moving in that direction yet. Anyway, that's just my own opinion. Moving on, there is something called emphysema, and for non-smokers' lung, you can see the alveoli are nicely forming like covering the area entirely. And the lung is more like a balloon in a normal person. Okay? I already described this before. Air goes in, and for the most part, air can come out on its own without too much effort. For a smoker, the alveoli actually gets destroyed, and then they leave behind these huge, big empty spaces in the lungs. So for emphysema, the person would have loss of elasticity in the lungs, in the lungs, and that makes it laborious, laborious to exhale, right? Because it's no longer like a balloon, it's more like a paper bag. You blow air into the paper bag, the air kind of lingers inside the bag, right? It doesn't come out on its own. And that's what happens with emphysema. The air goes in and then it takes effort to breathe out. Okay. It's requires you to physically force the air to come out as opposed to coming out on its own uh, for the most part, right? And what that also does is because there's these extra empty spaces, these empty spaces are filled with carbon dioxide. Right? And combined with the fact that it's difficult to empty your lungs, you are basically increasing your residual volume. Residual volume is the dead air, right? They are just carbon dioxide. And normally it's about 16%. Now it's much higher, and it eats up your respiratory volume. Right? If you have more dead air, you don't have much volume left for getting oxygen into your system. So you might suffer from shortness of breath, right? You might get tired easily because, again, you don't have good oxygen circulation, right? So that's emphysema. Emphysema. Now, Combine emphysema with the increased risk of infection, a person might get chronic bronchitis. I can't spell this morning, so sorry. Chronic bronchitis. Bronchitis is inflammation of the bronchi, and chronic means is ongoing. Okay, and it's not uncommon for heavy smokers to get chronic bronchitis, especially later on in life. So emphysema plus chronic bronchitis would cause a person to have COPD. You might have heard of that before. Okay, chronic obstructive pulmonary disorder. And that's when a person has to carry an oxygen tank to help them breathe. Okay. Because the lung is just filled with too much residual volume. You cannot get enough oxygen into the person. They would have difficulty physically exerting themselves. Walking up the stairs, for example, it's like too hard. So, they have to wear the oxygen tank. Okay, that's that. All right, that's it for smoking. Let's talk about some other stuff. Two more slides and then we're done. This is pneumothorax. Pneumothorax is a situation where the lung collapsed, and there could be various reasons for the collapse. It might be a knife wound, for example. That's probably more common than you would think. But it could be, someone in a accident, car crash that causes the rib cage to break, and then the rib cage can actually the fractured rib cage can actually puncture the lungs as well. Sometimes your body have these things called cysts that can grow on any organs. These cysts is like a sac, and you have weird stuff growing inside. Like sometimes it's just fluid, but it's possible for cysts to have like hair and even teeth growing inside. And they grow on the organs, like on the lungs. In this case, they could grow on the kidneys, they could grow in the ovaries, like everywhere. Okay, and sometimes these cysts can pop, and when they pop, they create like a forceful force that would rupture the lungs in this case. Anyways, so if your lungs collapse, you can see in this picture, this side is okay, the other side is completely collapsed, then it detaches itself from the chest wall. Right? If the lungs are collapsed, then that means the visceral layer is no longer touching the parietal layer. So when you move your chest, your lungs is no longer going to be following the chest. So your chest is moving, but you're not breathing. Okay. And you can see that that's a very scary situation, right? If both lung collapses, then there's not much time to help the person. But with one side, the person can still survive. It's not going to be a pleasant experience, but the person will live until help arrive. And at the hospital, they would have to like re-inflate the lungs for you and wait for the puncture to heal. Okay, so that's pneumothorax. I know two people who have had pneumothorax, spontaneous pneumothorax. It just happens out of nowhere. And there's no stab wound or anything. Uh, both of them are teachers, so I don't know if it has to do with talking too much. Anyways, last one here. We have the carbon monoxide poisoning. Okay, so excuse me, carbon monoxide is a colorless, odorless, and tasteless poisonous gas. Okay, you cannot detect it with any of your senses. That is why you should have a carbon monoxide detector at home. And if you have one at home, you should not put it in the kitchen. You should put it at where you sleep because that is the most likely place where you are going to get carbon monoxide poisoning and potentially die from it. Okay. So why does carbon monoxide kill you? Because carbon monoxide binds to hemoglobin. Hemoglobin is the oxygen transporting protein in our red cells. And in the presence of carbon monoxide, it will choose carbon monoxide over oxygen. Okay. And your cells cannot use carbon monoxide, and basically you die from lack of oxygen. Okay. So, what are some sources of carbon monoxide if you live in a house? It could be your furnace if there's some kind of malfunction that could generate carbon monoxide. It could be from your car. If you forget to turn off your car, for example, and it just keeps it running, then the monoxide would build up and then it might go into your home. And it could also come from indoor burning things. So this was, I think, almost 10 years ago. Um, has to be more than 10 years ago. Some of you might remember if you're in Toronto 10 years ago, there was one winter which was really, really cold. And then there were these like freezing storms, and it causes a power outage that went on for like, a few days. I remember 3 days for me, anyways. So a lot of people were really cold. It was in the middle of the winter, and some people brought their propane burner into the home and then use it indoor, right? And that is not good because the burning, anytime you burn things in an environment that does not have a good circulation and has limited oxygen supply is going to generate carbon monoxide. Okay, and these people actually, some of them die, I believe, from carbon monoxide poisoning. Yeah, someone just say, there are incidents where people try to use an indoor burner with kerosene. That is also a risk, right? Burning a charcoal indoor, or sometimes people my thing, oh, it's so hot. We take a nap in the car running with the AC. That's also really dangerous. It's carbon monoxide building up. Anyways, if you are home alone and, let's say the furnace is producing carbon monoxide and then you're being poisoned from it and you don't know, some of the symptoms to look for would be like feeling dizzy all of a sudden, breathlessness, feeling a little bit nauseated. And if you don't have a detector, that's why this is dangerous. Because if you're home alone and you're feeling dizzy and headache and nauseated, what do most people do? Okay, most people, including myself, is gonna pop a Tylenol or Advil and then maybe take a nap, right? And that's why it's dangerous. If the carbon monoxide is building up and you don't know about it and you go to nap, that's how you can get poisoned further and potentially die from it, right? Okay, so if there's a monitor, it will basically detect it for you. And if you hear your carbon monoxide detector going off, you're supposed to open all your windows, and there should be a number that you can call on your furnace, like a sticker on your furnace to say, suspect of carbon monoxide leaking. I call this number, and we'll send some expert to help you. And that is it, everybody. That is the first unit of the course. There are two more units to go. Unit 2 and Unit 3, but that is the cutoff for your first test. Does anybody have any question at all? It doesn't have to be related to respiratory system. It could be about the test or any other earlier units. Any concepts you want me to review for you, let me know now before I
I
start lecture 5. Go ahead, please.
I have a question.
Sure.
Yeah. Why during the carbon monoxide poisoning, um, the automatic breathing of the body cannot uh,
Good question.
trigger?
Yeah. So how come you don't trigger autonomic breathing? So here's
Correct.
the thing. With the carbon monoxide poisoning, it's not that you're not breathing. You are breathing fine. You're still inhaling, exhaling. That's called breathing, right? But you're not breathing oxygen, right? You're not, or like you're breathing oxygen, but you're also breathing in the carbon monoxide. So the carbon monoxide is competing with the oxygen for the hemoglobin. Okay. And when most of the hemoglobins are occupied with carbon monoxide instead of oxygen, then you're not getting it into your system, right? So yes, you might start to breathe more. It might trigger your respiratory center, so you're breathing more. But unless you are outdoor now to get oxygen, right, you are still breathing in carbon monoxide, and that's not going to help the situation. Does that make sense? Carbon monoxide poisoning is not the, sorry, does that make sense? Or do you have follow-up question?
Yes, yes, yeah.
Okay, great. Carbon monoxide poisoning is not the only situation that could cause these kind of things. I read a story once where there is a lake near a village, and then the village is sitting in a lower elevation than the lake, and then the lake there was some kind of volcanic eruption under like at the bottom of the lake or something, And then it created a lot of carbon dioxide from the eruption. And because the village is near the lake at a lower elevation, carbon dioxide is heavier than oxygen and nitrogen. And so all those carbon dioxide moves to the village and basically sit in this low elevation. And whole village died as a result of that overnight, right? Because all the oxygen was being displayed, right? Same thing. Do you guys know helium, right? Helium, if you like the balloons that makes it flow, if you inhale the helium, it causes your voice to sound funny, right? Really high pitch. If you don't know about it, you can search it on YouTube. And so a lot of people are like having too much fun with the helium. They keep on sucking it and then, laughing about the funny voices that they make. But if you're inhaling helium, you're not inhaling oxygen. And a lot of people pass out from these kind of activities. Well, luckily, if you pass out by sucking in helium, is okay. Because once you pass out, you start breathing again, oxygen, and you should be okay. But not so much for carbon monoxide or carbon dioxide in this case. Um, okay, so someone asked me about the pressure law again. So pressure is very straightforward. Just remember, if the volume goes up, then the pressure is gonna go down. Right? The whole point about breathing is you want your lung volume to get bigger to a point where the pressure in the lungs is below the outside pressure. Right? If they're equal, then there's no airflow. But if you can drop the pressure in the lungs by expanding your lungs, then air is going to flow in. When it's going to keep on flowing in, and as air flows in, the pressure goes up, goes up, goes up until it's equal. And then if you compress your lungs, right, then the pressure goes up higher than outside. Then now air flows out, and they drops until they're equal again. All right. So that is that. Okay, I won't keep you for too long. I just want to do a little bit of intro to lecture 5. So that way, Friday we will just be able to let's see. Yeah, Wednesday we're gonna be able to take some notes and yeah, I'm just trying to finish off before the engagement week. Okay, so I'm just gonna do a few slides here with the nervous system. I know it's not on the test and it's hard to focus on something new while I'm sure you have a bunch of tests this week, right? Not just me, right? I would assume you have similar assessment for chem and math and whatnot, right? Okay, let's move on. Yeah, almost every day. Yeah, yeah, I know, I know. Okay. So here we are starting lecture 5, which is unit 2. Unit 2, we have the nervous systems for 3 of the lessons, and followed by no two sorry two lectures on nervous system, and then we have special senses like the eyes and the ears, and then we have digestive system. Okay, the hardest would be the nervous system at the beginning. It's like a lot of strange concepts, um, but we'll try to break it down. This is a picture of the end of a neuron when it's trying to communicate with another neuron, and we're going to learn about this process towards the end. So here we go. The neurons is only part of your nervous tissue. Let me just show you something we did last semester, okay? Like a blast from the past, if you would. If you were with me last semester, we did this table, right? With the tissue, and then there's different kinds of tissue, epithelial tissue, connective tissue, and then we have muscle tissue and nervous tissue. So there are 2 kinds of nervous tissue. We have the neurons, which people call brain cells, but doesn't have to be brain cells. You can have like, in the spinal cord as well. And then there are also glial cells. Glial cells. Okay, so those are the 2 kinds of nervous tissue. Neurons generate and pass on electrical signals. Okay, it communicates with one another. And then we have the glial cells, which are also known as the neuroglia. They are there to support, protect, and nourish the neurons because neurons are very precious. If you lose neurons, they don't come back, and neurons don't divide. They don't do mitosis. Okay, you lose them, you damage them, they are gone forever. So the glial cells are there to protect them and to support them. They outnumber the neurons 1 to 9. Okay? For every neuron you have, there are 9 glial cells that would help support their function. There are different kinds of glial cells, and we will be learning the names of some of these things. Probably not today. Okay, maybe next class. So let's start with a drawing. You know what? I'm just gonna start a new one and I'll post both of them just so it is more organized that way. So this is, yes, 215 class notes. I'll call this one lecture 5. And then the other one that we did, I'll call it lecture 4 so you can tell the difference. Okay, both are taken today. So let's learn about the structure of a neuron. Structure of a typical neuron. Hey, they don't all look like this, but this is a typical neuron. So you can draw it like this, okay? Draw a big one. There's a little starburst here, like a little explosion, if you would. And then you have a tail. And then it will end in a little bulge like that. Okay, so this is what a typical neuron look like, and you would have the nucleus right here. Okay, so first of all, this here is the cell body. Okay. You would find typical organelles here. Okay. So the mitochondria, the endoplasmic reticulum, all those things you will find in the cell body. Okay. And over here in the middle, we have, of course, the nucleus. The main function of neuron is to pass on electrical signals, right? So it has to receive electrical signal from one end and then pass it on the other end. And the ends that's receiving electrical signals are these little projections that are coming out from the starbursts that I've drawn. Okay, these are called dendrites. Okay, dendrite for singular, dendrites at an S for plural. They receive signals from another cell. Usually, but not always, a neuron. Okay? So it could be receiving signal from another neuron, but it could be from other things as well. And I'll tell you what these other things are next time. Okay, so these are dendrites. Now, these signals that are coming in can be green signal, green lights, green signal. So these are excitatory signals. Okay, so these signals would tell the neuron to pass on the information. not every signal is has to be passed on. Okay, there are sometimes you have to trigger inhibitory signals. Okay, which would be like these red ones. Inhibitory signal. Right. So to give you an example, if you want to do a move this way, okay? If you want to curl your bicep, then you have to inhibit your tricep, right? Tricep is the back. If both bicep and tricep uh, contracts at the same time, then your arm is locked. It cannot move in one way, right? So to move this way, you have to excite this muscle and inhibit the other muscle. To move the other way, you have to excite the tricep and inhibit the bicep, right? So not every signal is about green light. There are some situations you have to stop transmitting certain signals. So all these incoming signals will be received by the dendrites. And at any given moment, it's possible to have multiple green signals and multiple red signals going into a neuron. And so the cell body needs to add them all up. Okay. It has to count all the green signals and all the red signals and see which one is stronger. And that's the one that's going to be transmitted or not transmitted in some cases. Okay. So let's say we have enough green signals, then we're going to pass it down this long tail looking structure. Okay. So this tail is called the axon. The axon. Some neuron has two, have two of these axons, okay, but a typical one would only have one axon. Some axons are exposed like this, naked axons, we call them, but other axons, they would have little um, insulation that goes around them. Okay, so these insulations, they are called myelin. Okay, and they leave a little bit of gaps every now and then. Right? So these are called myelin sheath. Myelin sheath. And the function of myelin sheath is to speed up conduction. Okay. So if we are passing on a signal, instead of passing down the axon like so, the myelin sheath forces the signal to jump from gap to gap. Okay? And it's able to get to the end faster. If we lose the myelin sheath, then the signal will be lost along the way and it will never get to the end. Okay. The myelin sheath is like insulating a copper wire. Okay. You know, the wires that we have, right? Basically, the plastic that goes around it is insulation, right? Allows the material to conduct the electricity faster. And these are electrical signals that we're conducting inside our neurons. Okay. Now, there are some gaps here and there. These gaps where there are no myelination, we call them nodes of Renvia. Okay? These are gaps where, which is a gaps with no myelin. Okay, we'll learn about um, what happens at those gaps at a later time. Now over here at the end, we have a little bulge here, and that is called the axon terminal. Right? The axon terminal will pass the signal to another cell. And again, usually another neuron, but it doesn't have to be. Okay, I'll tell you what the other thing might be in a bit. Okay, so that's a typical neuron with all the features and functions of the different parts. Any questions? Okay, I'm gonna do a little bit more notes, and then that will be it. So please start a new page if you can. This is the flow of information in the nervous system. So if you touch a hot surface, what happens? Right? If you touch a hot surface accidentally, then your hand is gonna automatically remove itself, right? This is called a reflex. So I'm gonna explain to you the series of events that happens from touching the hot surface to removing your hand. All right. Now, to understand that, we have to know there are two systems here, and I'll write this down in more detail for you next time. There is the central nervous system, okay, or the CNS, which has just two things in it, the brain and the spinal cord. Okay, brain, you know where it is up here. Spinal cord goes all the way down, right? Through the middle of the back. I can't show you really. All the way to your lower back. Okay, that's the spinal cord. So all the stuff that's in the brain and the spinal cord, it's part of your central nervous system. We'll learn about the structure of the brain and the spinal cord later on. But you have nerves on the arms and everywhere where else in the body, right? Like if you slap the hand, you can feel the pressure, you can feel the temperature change in the skin and everything, in the hand, in the arm, in the legs, right? So all those extra nerves is part of the peripheral nervous system. Okay, so everything else, we call this the PNS, CNS, and PNS. So let's start with like touching something hot, okay? Let's draw a candle here. Candle here, maybe something hotter, whatever you want. And we're gonna have the hand there. All right. Now there are different kinds of receptors on our skin. Some will be responsible for detecting pressure, like poking you with the back of a pen versus poking you with a sharp end. That feels different because of these pressure sensors. You have receptors for pain. You have receptors for texture and temperature. Okay. So over here, we're gonna have a sensor that would detect the change in temperature. And if it gets too high, it will cause the reflex to kick in and then you will remove your hand. Okay? So you have a sensory receptor. You just have to believe me, they kind of look like this. This is a sensory receptor, which would detect, again, detect different things. In this context, in our example, detects temperature increase. Okay, it's getting harder and harder and harder, and eventually up to a point, you're going to have to remove your hand. You have light sensor, light receptors in your eyes, right? You have chemical receptors in your on your tongue, right? Different receptors throughout the body for different purposes, okay? So this one detects temperature. So when the sensory receptors picks up the increased temperature to a particular point, it's too hot, then it will trigger a signal that will send the information to your central nervous system. Okay, so this pathway is called the afferent pathway. Afferent pathway is made up of sensory neuron. Okay, that carries sensory information. Okay, so this pathway is basically like a bunch of these neurons playing broken telephone, right? Except it's not broken. Okay, the information is accurately transmitted. Okay, one neuron tells the next, "Hey, the hand is burning. The hand is burning. The hand is burning," and then the information get passed on all the way, all the way, all the way to your spinal cord. Okay, so there's a little division here, and this is going to be your spinal cord. The reflex in this case actually does not involve your brain. Your spinal cord helps you make that decision. It allows it to happen faster. Okay, so these are sensory neurons. They transmit sensory information. In this case, the sensory information is about high temperature. It is too hot. Right? If we are talking about sensory neurons coming from your eyes, then they will be transmitting visual information, right? Sensory information for the ear would be related to sound, so on and so forth, right? So sensory neurons are neurons that will be carrying sensory information from the PNS. This is outside of the brain and spinal cord to your CNS. I'm going to pause for a moment for you to catch up and ask questions. Okay, so all these informations carried by the sensory neurons is going to go to the spinal cord. And inside the spinal cord, we have a special kind of neuron that has two axons. We call them bipolar neurons. This is called, it's a type of bipolar neuron, and it's an interneuron. Interneuron are only found in CNS. Only found in CNS. And what does it do? The interneuron will process sensory information and determine the appropriate motor output. Okay. In other words, it will analyze the sensory information coming in and decides what to do with it. Different situations require different responses, and sometimes the best response is not to respond. Okay. So in this case, the sensory information coming in is A, the hand is touching something that is too hot. So what's the appropriate motor output? What's the appropriate motor response? Motor response is like what you do with it, okay? Well, you remove your hand, right? Remove your hand. So that information will get sent out through an other pathway, back to the hand in this case, and will cause your hand to move away, right? So this is the opposite of afferent pathway. It's called the efferent pathway is made up of motor neurons that carries motor information, right, to an effector. I'll explain. Just copy first. So basically, for the blue one, it is PNS towards CNS. And then for the red one, it is coming from the CNS, and it's going out to the PNS. So what is an effector? An effector is basically a muscle, an organ, or a gland that will execute the motor output. Okay. This effector has nothing to do with the effectors we learned in the immune system. Okay, it's two different things. So in this case, the muscle would be the muscle in the arm, right? To move the hand away. But it could be an organ or gland as well. If there is some kind of dog running towards you or something, okay, and it looks angry and like, ready to attack you, then that's the visual input because you see it through your eyes. It's going to go to your brain. There will be interneurons in the brain that would interpret that. And then the motor output would be number one to your leg muscles. Oops, to your leg muscles to run away. Number two, your heart rate is going to go up because the motor output is going to go to your heart and you cause it to beat faster. And number three is going to go to your adrenal gland, for example, and cause a bunch of adrenaline to be released because you're ready to do the fight or flight response, right? So motor output can affect how your muscle moves, can affect how your organ functions, and it can affect glands, which essentially secretes hormones in most cases, right? Okay. Doesn't have to be hormone. Like it could, affect your sweat gland or something. You can start sweating in response. So like if you eat something spicy, right, automatically your body is gonna heat up and sweat a lot. That's an example of a reflex as well. Okay. It doesn't have to be like, hormone necessarily. So that's the flow of information. Okay. So along the way, for each of these paths, it consists of different types of neurons. We have the sensory neurons, we have the interneurons, and we have the motor neurons. Okay? So most neurons look like this, receiving the information, passing it on from the axon terminal. It's just that for the interneurons, they have two axons instead of one. Got it? All right, so one more time, you touch the hot surface, the receptors in your hand will pick it up. It will trigger a signal that goes up the sensory neurons through the arm to your spinal cord. Your spinal cord decides it's too hot and you got to remove your hand. And the signal will come back out and then you will remove your hand. Okay? That's the overview. We will spend more time talking about this later on when we, take a closer look at the spinal cord and we'll see how the neurons are coming in and going out. But that will be on Wednesday. Okay? That's it for today. If you have help, I need help with the test, just email me. I'll be sure to reply you before then, before the Friday. Okay? Take care, guys. Bye-bye.
Yeah, bye.